So there's a bunch of different options that have recently come out in terms of treatment. There are two new medical treatments that are currently under investigation right now. One is a class of medication that previously was used for a different indication called the selective progesterone receptor modulators. And basically what that drug does is that it interferes with the progesterone receptors in the fibroids. And what the research has shown so far is that by taking this medication, it can actually shrink the size of the fibroids and improve any bleeding symptoms and other symptoms that might also come along with the fibroids. That's one of the drugs that's currently in clinical trials. Another new drug that's in clinical trial is something called a gonadotropin receptor hormone antagonist. Now, GnRH antagonists. Until now, GnRH agonists have been used. What the difference between an antagonist and an agonist is basically just the way it works in the body. An agonist increases something, an antagonist decreases it. The GnRH agonists, which we currently have available to us on the market, involve a monthly injection. It's a very expensive medication. It could be anywhere between $750 to $1,200 a month. For the medication, and many insurers do not cover it. Medicaid, again, it depends on the copayer and it depends on what their particular plan is. Sometimes yes, sometimes no. It's definitely not consistent. And what we end up seeing with that medication works by basically putting a patient temporarily into menopause. Cuts off the hormone production at a high level. The advantage to that is that women, when they're in menopause, the fibroids will typically shrink, as well as they won't bleed because they are in menopause. The newer medication is this GnRH antagonist, which works to block that receptor. And what ultimately happens is it does the same thing by putting a woman into a temporary menopause state and causes shrinkage of the fibroids and improvement in the bleeding symptoms. But the difference with this is that as opposed to the agonist, the antagonist can be taken orally. So we don't need an injection, which automatically saves a tremendous hassle. And the anticipation is that it'll be significantly cheaper once it's on the market. It would seem that you would have to take it continuously in order to maintain that effect. But in some of the earlier trials that have been done, there seems to be some persistence of effect even with just taking it for 3 months. So after discontinuing it after 3 months, up to a year out, some of the earlier trials are showing that there is improvement in the symptoms. Right now, I am directly involved in about 4 trials. One of them is a drug trial, the GnRH antagonist. The other ones are procedurally related fibroid trials, also on new technologies in ways to be able to treat fibroids. It is in the very early stages. It's a phase 3 trial, so this is something right before it would potentially be available for marketing, but it's still in the very early stages of the trial. We're probably not going to see results that'll be available for at least 1 to 2 years minimum. I can tell you that on the phase 2 studies, it did show very promising results. Mm-hmm. Another treatment option that we're working on is radiofrequency ablation of fibroids. Mm-hmm. Basically, what that is we take a needle and we insert a needle into the fibroid. And that needle has a lot of other little needles that come out from the primary needle. And we activate energy, which then causes heating and destruction of the fibroid tissue. Yes. The traditional one, the one that we originally studied, involved a laparoscopic approach where we put a camera in the belly and use the needle to go through the abdomen into the uterus, into the fibroids under ultrasound guidance and laparoscopic guidance. The new one that we're currently studying actually goes transvaginally, so there's no incisions involved. And it is theoretically possible that this may be able to be done with just some very basic sedation in the future, but for the time being, for the purposes of the trial, it's going to require general anesthesia in an operating room in our ambulatory surgery center. Another area that we're looking at is high-frequency focused ultrasound ablation of fibroids. It's probably the closest to the Star Trek idea of going into a machine and getting beamed in and walking out healed. Essentially what happens in this procedure is a patient is put into an MRI machine, and while they're in the MRI machine, ultrasound waves are used and focused onto the fibroid. And it's possible by using multiple ultrasound waves, if you focus it on one point, to get very specific heating to that one area without damaging any of the surrounding tissues. It's most likely going to be the least painful because it is truly the least invasive. All it entails really is lying down in the MRI machine. We're actually involved in a trial of a new device for it, but there actually is one commercially available currently. However, it is not covered by any insurer at this time. There's no CPT code for it.